When Isaac Starr and his team purposefully sabotaged the right ventricles of animals in their 1943 experiments, they didn't expect to fundamentally shake our understanding of the human heart. Their findings, however, contradicted their initial assumptions, triggering a dramatic re-evaluation of the role and importance of the right ventricle. They had set out to prove the right ventricle's irrelevance, only to reveal its intricate significance in a series of unexpected revelations. Let's dive in and find out all about the right ventricle. In our understanding of right ventricular failure, it's essential to focus on 4 primary mechanical factors: excessive preload, excessive afterload, reduced contractility, and reduced lusitropy. Picture them as key players in a complex game, where each move they make impacts the others. Excessive preload, for example, is not an isolated issue. When preload increases, it often triggers a series of chain reactions. It leads to increased pulmonary venous pressures, resulting in an increased afterload. This is because the excess preload sets off a pathophysiological cascade. Imagine dominoes toppling over in sequence. This cascade involves hepatic and renal venous congestion, causing an increase in sodium and fluid retention. Now let's think about excessive afterload. When the afterload increases, the right ventricle dilates and worsens tricuspid regurgitation, creating an excessive preload. So, in this game, one player's move directly affects another. It doesn't stop there. Excessive preload also directly influences contractility. When preload becomes excessive, it can impair the contractility due to a leftward shift in the septum, increased ventricular interdependence, and decreased coronary perfusion pressure. All these mechanical mechanisms, excessive preload and afterload, reduced contractility, and reduced lusitropy, may work alone or together. And when they do, they may ultimately lead to either acute or chronic right ventricular failure. Remember, certain conditions like arrhythmogenic right ventricular cardiomyopathy, abbreviated as ARVC, or the use of a left ventricular assist device, known as LVAD, can impact these mechanisms and contribute to right ventricular failure. Let's take a moment to consider the molecular mechanisms that contribute to right ventricular failure. It's a lineup of usual suspects: ischemia, fibrosis, hypertrophy, and metabolic dysfunction, among others. Let's start with ischemia. An acute ischemia may result from myocardial infarction, a sudden blockage of a coronary artery. In contrast, chronic ischemia develops over time due to an imbalance between the supply and demand of myocardial oxygen. This imbalance is often caused by chronic pressure overload. Chronic elevated afterload plays a big part in this imbalance. It results in myocyte hypertrophy, which increases the oxygen demand, and reduced perfusion pressure, which decreases the oxygen supply. It's like demanding more fuel for a car, but supplying less of it. Next up is fibrosis. Excessive activation of cardiac fibroblasts can impair diastolic function and excitation-contraction coupling, worsening the overall myocardial performance. Interstitial fibrosis can be detected non-invasively using cardiac magnetic resonance imaging to quantify extracellular volume. Higher extracellular volume, seen at the red end of the scale, indicates more interstitial fibrosis, while normal values are typically in the green range. Myocyte hypertrophy initially serves as a compensatory mechanism to deal with this increased pressure. However, progressive hypertrophy demands more oxygen than supplied, resulting in right ventricular dilatation, impaired contractility, and eventually, decompensation. Switching gears a bit, let's talk about metabolic dysfunction. In patients with pulmonary arterial hypertension, there's an increase in glycolysis and glucose oxidation and a decrease in beta oxidation. It's like switching from diesel to unleaded in a car. It's a relatively oxygen-efficient process, but at the cost of lower ATP production. However, this metabolic switch is not without consequences. Excessive fatty acid substrates in relation to the mitochondrial oxidative capacity can lead to an accumulation of toxic lipid species, a state known as lipotoxicity. In pulmonary arterial hypertension, excess right ventricular mitochondrial fission or fragmentation leads to an imbalanced state. This imbalance is characterized by excessive fibroblast proliferation and suppressed apoptosis, potentially contributing to right ventricular fibrosis. We should also acknowledge that systemic metabolic dysfunctions, like obesity and insulin resistance, could be modifiable risk factors for right ventricular failure in susceptible patients. We'll now delve into the diagnostic tools and evaluation techniques used for right ventricular failure. This process involves several crucial components, including a detailed patient history, physical examination, and various diagnostic tests. Starting with the patient's history, we're on the lookout for symptoms indicative of right heart failure. These can range from dyspnea and early satiety to abdominal fullness and lower extremity edema. Additionally, associated conditions such as coronary artery disease, left heart failure or valvular disease, chronic lung disease, or venous thrombosis can provide key insights. The patient's social history and family history can be equally enlightening, as factors such as tobacco use, history of anorexigen use, and family history of pulmonary arterial hypertension or left heart failure can play a role. Moving on to the physical examination, there are a few key indicators we're looking for. These can include elevated jugular venous pressure, right ventricular heave, a loud second component of the second heart sound or P2, and signs of hepatic congestion like an enlarged, pulsatile liver. The patient's brain natriuretic peptide, BNP, level can serve as a vital serum biomarker for right ventricular failure, with elevated levels being a cause for concern. An electrocardiogram, ECG, can reveal potential issues such as right atrial dilation, right ventricular hypertrophy, and right axis deviation. Echocardiograms provide a wealth of information about right ventricular measurements or findings, volumes, ejection fraction, and more. These include tricuspid annular plane systolic excursion, TAPSE, tissue Doppler velocity at the lateral tricuspid annulus, and right ventricular strain. Then we have the cardiac MRI. It can measure right ventricular volumes and ejection fraction, detect delayed gadolinium enhancement or fibrosis, assess the pericardium, and reveal left heart disease or intracardiac shunts. Finally, right heart catheterization is the gold standard for assessing pressures within the right side of the heart and the pulmonary arteries. It's an indispensable tool to detect pulmonary hypertension, estimate left atrial pressure, and calculate the cardiac output or index. Today, we're going to take a closer look at the pressure volume loops created during preload reduction. These loops provide an illustrative way of understanding ventricular function, specifically contractility and afterload, panel A. If we examine these loops, we find that the end systolic point for each loop gives us a maximal ratio of pressure to volume. By plotting a linear slope through these points, we can determine what we call the end systolic elastance, or ease. This is a measure of contractility that isn't influenced by the load on the heart. Now, let's talk about estimating afterload, panel B. We calculate this by taking the end systolic pressure and dividing it by the stroke volume, which is the width of the pressure volume loop. This gives us what's known as the effective arterial elastance, or AEA. With these two measurements, ease and AEA, we can then determine the coupling between the right ventricular contractility and afterload, panel C. This is referred to as right ventricular pulmonary arterial, RVPA, coupling. The optimal ease to AEA ratio, or the ratio at which the maximum transfer of potential energy from the ventricle to the circulation occurs, is between 1.5 and 2.0. In conditions such as pulmonary hypertension, ease initially increases to offset the increase in AEA, maintaining RVPA coupling. However, eventually, when there's no additional contractile reserve, the increase in AEA surpasses ease. This disproportionate increase results in what we call RVPA uncoupling, indicated by a ratio below 0.6 to 0.8. Importantly, this state of RVPA uncoupling has been associated with worse outcomes for patients. Tricuspid annular plane systolic excursion, also known as TAPSE, which is measured through M-mode echocardiography. TAPSE tends to decrease when right ventricular function is impaired, as shown in panel A, the left image. Next, we use echocardiographic Doppler assessments to determine the maximal velocity, v, of the tricuspid regurgitation jet. We add this to the right atrial pressure, or RAP, estimated during inferior vena cava imaging. This gives us an approximation of the right ventricular systolic pressure, or RVSP. We calculate RVSP using the modified Bernoulli equation. RVSP equals 4V squared plus RAP, panel A, right image. In the absence of obstructions in the right ventricular outflow tract or pulmonic stenosis, the RVSP equals the pulmonary artery systolic pressure, also known as PASP. We can then calculate the ratio of TAPSE to PASP, which gives us an estimate of right ventricular pulmonary arterial coupling. To evaluate leftward septal displacement, we use the eccentricity index. This is the ratio of the anteroposterior dimension, or D1, to the septolateral dimension, or D2. When D1 equals D2, there is no septal displacement and hence no evidence of right ventricular overload, panel B, left image. However, when D1 exceeds D2, as shown in the middle and right images in panel B, this indicates right ventricular overload. Depending on the extent of the discrepancy, this can indicate either mild or severe septal displacement. Let's delve into different therapeutic strategies for right ventricular failure, looking at both pharmacologic and non-pharmacologic approaches. First up, to achieve preload reduction, loop diuretics such as furosemide, bumetanide, or torsemide are commonly used. Thiazide diuretics can also be used to enhance the response to loop diuretics. When medication isn't sufficient, ultrafiltration might be considered. Atrial septicectomy is another option for severe cases of pulmonary arterial hypertension. When it comes to afterload reduction, we have several tools in our kit. We can use long-acting calcium channel blockers like nifedipine, diltiazem, or amlodipine. Continuous inhaled vasodilators, like nitric oxide or prostacyclin analogs, can be useful. Endothelin receptor antagonists and phosphodiesterase 5 inhibitors are also options. For cases where these medications aren't enough, mechanical obstruction alleviation, aortopulmonary shunt, or lung transplantation may be considered. Inotropic support, which enhances the heart's contraction force, can be provided by beta-1 agonists like dobutamine, epinephrine, or dopamine. A phosphodiesterase 3 inhibitor called milrinone can also be used. Vasopressors and digoxin might be options too, particularly in patients with chronic RV failure. Finally, in severe cases of right ventricular failure that are unresponsive to pharmacological therapy, mechanical circulatory support may be used. This can involve percutaneous intracorporeal microaxial pumps, extracorporeal RVADs, or durable ventricular assist devices configured for right ventricular assist, among other options. Remember, these are general guidelines. Every patient's case is unique, and the treatment plan must be tailored to their specific condition and needs. In conclusion, the right ventricle, once considered less crucial, now holds a central role in our understanding of many health conditions. Its complex anatomy, integration with the left ventricle, and specific pathophysiology underscore the need for further research to enhance our understanding and ability to treat diseases involving the right ventricle. If you've enjoyed and learned from this deep dive into the intricacies of the human heart, please don't forget to like this article and share it with your colleagues. To stay updated on further discoveries and insights, be sure to subscribe to our channel. Every bit of your support encourages us to continue unveiling the wonders of medical science. Thank you.